introductions. As we discussed just now, there is a need to discuss status epilepticus among emergency medicine physicians or units, partly because status epilepticus is possibly one of the common situations that you face. And secondly, in certain hospitals, they may not have immediate contact to neurologists in managing these patients. So we will need to learn some basic and as well as to improve our service in order to improve the outcome of patients with status epilepticus. So I can see that now we have about 16 participants, 18 now, and some of you are juniors, and I would like to see your face later on because I think the discussion is actually more important than the presentation itself. Okay, so I'll start with the topics first, then I will stop at a few points, maybe 4 or 5 points, and then we can discuss what to do next. So this is an update from my lecture in Status Epilepticus 2020, and there is a lot of the updates today are related to the response of a survey that we have performed last year, asking what would you do for status epilepticus in various hospitals. We have captured response from 23 tertiary hospitals, which is 95.8% of all tertiary hospitals, government hospitals in Malaysia. We have also response from 4 university hospitals and a few private, a few districts, and some clinics. As you can see here, 33% of the respondents from these hospitals are from emergency department. So this is the first question which I would like to discuss. So what is available in the ambulance? Because we know that the earlier we treat, the better the outcome will be for status epilepticus. So if someone call for status and then ambulance arrive, what can be given immediately in the ambulance before reaching the hospitals? So you can type your answer in the chat. I will. Okay, thank you. Thank you. So you can type your answer in the chat, and I will, and then we can discuss a bit more. Thank you, Dr. Is. A, B, Dr. T, Dr. Tan. IV diazepam. So A, B are the common answers. Huh? Any other answers? How about C, D, E? No other options. Okay, Dr. Chow. Thank you, Dr. Chow. Is Dr. Lian chose A and C. All right. But C is actually a less common options available when in our survey. This is a response. As you can see here, for IM midazolam, there are only about 45%. This includes people who are from internal med, who are in the tertiary hospitals. They are not mainly district. So you can see that IM midazolam is not a common practice. And we will stuck, if we choose IV diazepam, we will stuck because when there's no IV line, we'll have problem. If we choose rectal diazepam, then it will, for adult ladies, it'll be a bit inconvenience. Even adult men is not that easy to give rectal. Okay, so as what Dr. Nasrina said, is available but need to take it from the red zone. So it makes it a difficult, challenging, but isn't it diazepam also you have to take from the red zone as well? And the problem is it's not available in the ambulance. Most ambulance has no MIDA diazepam. So in your hospital, is diazepam or MIDA available in the ambulance? Do you think the ambulance that you send out has MIDA or diazepam?
Unless if they get information from MCC that the patient is already known seizure, they might bring before the ambulance being dispatched to the actual place. So
Yeah.
that is one of the possibilities.
Yeah, thank you, Dr. Is. So in fact, you just imagine someone had a seizure, then they call ambulance. It takes a few minutes, and the ambulance say, "Okay, we better go to this place." But the patient got seizure. I need to get some diazepam, and it will go and get it from whatever red zones. It will take another few minutes. Then it could go back to the ambulance, go to the house, and if seizure continue and it give diazepam, by that time, it will be already 20-30 minutes off. Especially in the traffic jam area like KL, it'll be even longer. This is for hospital ambulance, but what happened to other ambulance like St. John's Crescent? There's no benzodiazepine available because there is no medical staff in those ambulance. How about fire and rescue? I'm not sure whether you watched the movie 911. 911 are mostly firefighters, and they can do CPR, they can back the patients, they can even give drugs. They are trained to give drugs. But our firefighters in Malaysia are not trained. So most often, patients who are sent by the private ambulance or firefighters, they are not treated until they reach the emergency department. So it's very, very late. So this is our problem. We need to improve on this. We are still sorting it out. How can we make benzodiazepine available in the ambulance, despite it being control items? But time is brain, and how high the dose can we give? The problem is that a lot of times we are depending on IV diazepam, but IV diazepam need intravenous cannulation or granular. Rectal diazepam, as I said, for children is easy, for adult is quite difficult. And you can see that this is American Epilepsy Society guideline. The first choice is intramuscular midazolam, which is easier, faster, and you don't need an IV granular. So IM nasal buccal, I'll go through this a little bit more today. So you can see on the left is buccal midazolam. It does, even when the patient is having biting, we can just open the lateral mouth and then push the midazolam into the buccal region. Then it will be absorbed. It will be absorbed within a few minutes to the brain, provided they don't swallow. Whereas for intranasal midazolam, we have it in a few hospitals, but you need an aerosolized head. So the atomized aerosols, you can see that the atomized head or spray aerosolize the midazolam into smaller particles for the ease of absorptions through the nose. So the nose is less easier to be applied, whereas the buccal is easier. But if you don't have midazolam in the ambulance, we can't do that either. So some company has produced ready-made nasal spray of both diazepam and midazolam, but this is very expensive and it's not available in Malaysia. So in Malaysia, the easiest way is we break the ampule of diazepam, withdraw 5 to 10 milligram, which is only 1 cc. And then we push it through to the buccal region. This will have a very fast absorptions. If not, if we have a needle, then we can straight away use IM midazolam. IM midazolam has more better bioavailability because it won't swallow and it reach the brain faster. So you can see this RAMPAD trial. RAMPAD trial is comparing IV lorazepam and IM midazolam. IV lorazepam is very good, but not available in Malaysia. So you can see that IM midazolam can be given faster. From box opening to cessation and convulsions is faster than lorazepam or almost similar, partly because it is faster in administrations. Although it achieves the effect slower than IV, but is faster in administration, and therefore in total time is still compatible or even better than IV lorazepam. All right, first line, either pre-hospital or in the emergency, you don't have to find IV granular struggle when the patient having seizure is difficult. The first choice, even in the emergency itself, you can consider IM midazolam, same dose as diazepam. Okay. If okay, then I'll go on. You can see why Laura is better. Lorazepam has a long half-life. Even clonazepam has a very good long half-life, but diazepam mida has a short half-life. So the duration of action, this is not talking about the total half-life in the body. It's talking about the duration of actions that will work for seizure control. And that is the problem when we use diazepam. Let's say we give one dose, patient seizure stop. Then after 30 minutes, seizure recur. What will you do? You probably want to give another dose of diazepam. After that, it stopped for a while, then it recur back again. Wow, very complicated when we have recurrent seizure, which is only controlled by diazepam for a very short period of time. And therefore, we need to find another solutions. All right, so the first solutions, fast and high dose, where we can consider IM midazolam. The second solution is this. So let me explain first before you choose. All right, so in most protocol, we say, I give diazepam, seizure stop, I will stop as well. If seizure continue, I give second dose of diazepam. If there is still another continuous seizure ongoing, I will give phenytoin. All right, this is our Malaysian practice, diazepam, phenytoin. But there is a paper talking about this. This irrespective of seizure control, after 2 doses of diazepam, they will go ahead and give phenytoin, even if the seizure has stopped. With the rationale that I give just now, diazepam actions or duration of actions is very short. There is another option is when we are giving the first dose of diazepam, we will start prepare the phenytoin infusions. When we give second dose, we'll give together with phenytoin. And the option D is diazepam and phenytoin give together in the very beginning. Which one would you prefer? A, B, C, or D? Thank you, Dr. Lien. You are fastest. Dr. Chow. Thank you. Most people choose C. You are not following the Malaysian guideline of A, which is diazepam, phenytoin. But with the rationale, C, I think is the best. So very often when the first dose of diazepam doesn't work and we need to give second dose, it is better that we start preparing the phenytoin. What is the problem with phenytoin? Phenytoin has to be given very slowly with 50 milligrams per minute. So let's say a patient with 1,000 milligram phenytoin has to be given over 20 minutes. Phenytoin, most of us didn't use the high or maximum dose up to 18 milligram, and some paper in our center, we always train our team to give as high as 20 milligram, so that we don't undertreat the status epilepticus. So just imagine someone with 60 milligram, 60 kg, 20 milligram per kg will be 1,200, whereas 70 kg patients will be 1,400. So in the old days, many of the books say 750 milligram. It is not enough. So minimum 1,000. If 1,000 for small size, for the bigger size patients, we will need to consider higher dose. Do you do ECG routinely when you give phenytoin infusions? Phenytoin can cause arrhythmia in some patients. Thank you. Thank you, Dr. Nasrina, Dr. Chow. In fact, in our survey, you can see that there are only a certain percentage that will do ECG monitoring. Most often, when we are so rushed, patient is having seizure, we are shouting, we want to take blood, we want to set line. It is very challenging to do ECG at the same time. But it's important because phenytoin can cause arrhythmias. So once the seizure has slowed down or the patient become less chronic or less tonic, then we should start putting the ECG machine on the patients to monitor for arrhythmias. Thank you. Dr. Len mentioned about elderly. Not only elderly, arrhythmias occur in young patients as well. So in 2009, there is a thoughts or discussion about whether we should give two together, which is option D. Option D is diazepam plus phenytoin. So in this concept paper, this is just a concept paper talking about giving lorazepam and phenytoin together over 30 minutes, partly because phenytoin takes some time to complete the infusions. This doesn't work. There is no further study on this, and whether this will work or not is not proven, and no study has performed to differentiate lorazepam phenytoin versus the lorazepam alone until a very late study on the pediatrics, which is on diazepam phenytoin combinations. Therefore, in order to save time, the suggestions or the recommendation is to start prepare phenytoin as soon as possible. Even when we start giving the first dose of diazepam, we should consider giving phenytoin or prepare the phenytoins, partly because the longer the seizure, the more difficult it will respond to treatment. So combinations study has been performed, as I said, phenytoin and diazepam, but it's also sequential. They are not together. The only paper that I can find which give simultaneous benzo and anti-epileptic drugs is levetiracetam and clonazepam. Unfortunately, there's no difference between the two groups, partly because clonazepam has a much longer action of duration. So those who are given clona or clona plus levetiracetam doesn't seem to have a difference. But we don't know if it is diazepam plus phenytoin versus diazepam and phenytoin later. There's an animal study which looking at the simultaneous administrations based on the neurotransmitters concept. So this animal study asking a questions, if we are giving mida, valproate, and ketamine together, whereby mida is a GABAergic agonist, ketamine is an NMDA antagonist, what will happen? So technically, when they give mida and ketamine, the response is better than sequential or mida alone. But when they give three or simultaneously, mida, valproate, and ketamine, the response is very good. As you can see, the difference between simultaneous combination or sequential. So if you are giving sequential drugs, for example, diazepam and phenytoin later, it actually takes much longer to complete the whole or full dose, and the response will be much poorer than those who are giving combination from the very beginning. And remember, phenytoin is sodium channel blocker. This may be uncommon for some of you. So besides phenytoin, what else do you have in your department? Wow, ABC, AB. So it's available, mostly available. B, sodium valproate. So when would you use sodium valproate if you have sodium valproate? Yeah, correct. C must indent. So while waiting for levetiracetam, it will take a while, sometimes 10, 20 minutes. So what will you do? So, in which patient you will consider phenytoin and which patient you will consider sodium valproate? Thank you. I think most hospital in Sabah only has A, correct? Phenobut. But phenobut is mostly used for pediatrics patients. So when would you consider sodium valproate is the questions. If it's available, so when should we use and why sodium valproate? Why not phenytoin? Partly because the better phenytoin alternatives is forced phenytoin, and I'll explain this a little bit later. What is the difference between phenytoin and forced phenytoin? All right, so this is the response based on seizure types. So if it's generalized or if it's focal or non-convulsive, the choice is slightly different in for different people. So for generalized, we go ahead with phenytoin, whereas for focal status, some people start to consider sodium valproate, especially the elderly, or especially those who are still alert conscious or focal jerks. They will go on with sodium valproate first. In the recent submissions, when we submit our paper, there is a comment asking us, how about pediatric patient with a certain epilepsy syndrome, for example, Dravet syndrome. Dravet syndrome is an infant tau status epilepticus that will get worsened with phenytoin or any sodium valproate. And their comment is that in those cases, if we know patient has a Dravet or infant, we should consider either phenobut or sodium valproate rather than phenytoin. That's why we need to think outside the box. We need to know what other options do we have. And in America, they don't have phenytoin. They use phosphenytoin. They have valproate and levetiracetam. Let me show you the study on these three medications to highlight the importance of using different other alternatives. As you can see in this guideline, the phosphenytoin dose is 20 milligram per kg. Just imagine when I talk about, just try to recall when I talk about phenytoin, we also need about 20 milligram per kg to achieve the better response. Don't underdose. So this is the 2011 study. They are comparing epilim, phenytoin, and levetiracetam. They found that epilim is very good, much better than phenytoin, much better than levetiracetam. And those with deadly etiology, as listed here, have poor seizure outcome or morbidity. Similarly, those with a STESS score, and just remember, this score is a very simple to apply score. Someone who is comatose, someone who has non-convulsive status or very old, their score is high, and the morbidity and mortality will be high as well. All right, but what is the problem of this study is that the phenytoin is given slowly over 20 to 30 minutes. Levetiracetam, the dose is actually very small. 20 milligram per kg is a very small dose for levetiracetam in status epilepticus. So therefore, subsequently, they have modified the study by giving phenytoin faster using phosphenytoin, or given a higher dose of levetiracetam. As you can see here, this is published in New England Journal. Phosphenytoin dose is the same, but it is given over 10 minutes, different from phenytoin, which will precipitate. Levetiracetam dose is 60 now, different from the 20 milligram in 2011. So our lesson that we learn here is we must use adequate dose, not under dose whenever we are treating status epilepticus. So in the very beginning, very old days when I start my neurology practice, sodium valproate, we only give 10 milligram per kg. 10 milligram per kg is a very small dose. So nowadays, we push high using 40 milligram and give bolus over 10 minutes. As compared in the old days, we'll give 10 milligram per kg over 1 hour infusion. Those regime is very, very slow and inadequate. Okay, so give fast and as fast as we can. And in this case, 10 minutes. That's why sodium valproate will be very essential to make it available in most emergency. Mainly, if the phenytoin doesn't work or the phenytoin has a concern of being given to over a very long period of time, we should consider sodium valproate, which can be given earlier and faster. So what if there's no IV levetiracetam or sodium valproate? As you can see here, some of the hospital have to have special have to indent, have to wait. We can consider oral tablets, and oral tablets is usually with the patients. So if the patient is already on carbamazepine, for example, so patient is on carbamazepine, maybe he has missed the dose for 2 or 3 days, come in with status epilepticus. What can be given? Must it be diazepam phenytoin? Or must it be levetiracetam epilim? No, it's not necessary. All these choices. If someone who are on carbamazepine and still can take orally, or there is an NG tube, we can give the carbamazepine dose, high dose through the NG. But technically, it will take about half an hour to work. So in the beginning, we'll still need diazepam to control the seizures. One size fits all, it doesn't work in such a way. We always look at the types of seizure or status epilepticus so that we can treat them accordingly and don't be too aggressive to intubate patients whenever they are less severe. So remember, non-convulsive status are patients with no seizure or no convulsion. I'll give you a few examples. Okay, so remember some of the mimics. On all these mimics are not true seizure. I have a patient with psychogenic status epilepticus come into hospital and intubated every time when she presented herself because it was thought to be a status, but actually it's psychogenic and the EEG will be normal during the seizures. So I will go through the non-convulsive status and we'll go through one example of focal status epilepticus to let you understand that sometimes we don't have to be too aggressive or we have to consider other etiology or other managements. So a 78 years old woman with auto mental states. But patient had seizure before, then we know that possibly this is a seizure or status epilepticus. But if the patient has no previous seizure, we have this differential diagnosis. Is it an encephalopathy? Is it encephalitis? Or is it non-convulsive status epilepticus or post-ictal states? Sometimes when we are unsure or when the patient just had a seizure and now is confused, we can wait for a while to see whether she improved over 20 to 30 minutes. But if the patient doesn't wake up and there's no other suggestions like fever or any other past medical history to indicate this is likely a sepsis or metabolic causes, in those occasions, sometimes a small dose of midazolam, which you usually give 1 or 2 milligrams of midazolam, we'll see whether it will help to reverse the auto mental states. So for non-convulsive status, which option can be administered or considered? Most often, non-convulsive status will need EEG confirmations, but in emergency, some patients just have a seizure or have some patients have history of epilepsy and come in with altered mental states. We will need to consider non-convulsive status. So which one would you consider? Phenytoin, Dr. Is has answered. It sounds complex or rare to most of you, is it? Oh, thank you. Phenytoin. The problem is that if we are unsure whether, of course, phenytoin can be used for non-convulsive status, but the problem is if there is no EEG confirmations, we will be unsure of the diagnosis. So the only things or the only way to treat is to test with some small dose benzodiazepines. But nonetheless, let me give you another examples. So if you see a patient with altered mental states, but when you look at the eyes have left lateral nystagmus, continuous nystagmus, then maybe you will think, yeah, this may be a seizure. Or if look at the hand may have very minor twitch continuously. Then you may also thought, this may be a status epilepticus, non-convulsive, but there may be some subtle motor sign like twitching of the limbs or muscles or jerkiness of the eyes like nystagmus. In those cases, try some small dose midazolam, or if you think this is slightly a seizure, we can use IV phenytoin. Yes, of course, diazepam. If you don't have midazolam, you can use diazepam, but use a smaller dose to try and see. Especially the elderly, we won't give up to 10 milligrams straight away. We give a smaller dose because we don't want to change the mental states by using a high dose benzodiazepine. So this is the answer given. As you can see that levetiracetam will operate the midazolam and the phenytoins are the preferred choice in nearly equal percentage. So when do we suspect non-convulsive status and we will need to do EEG is when any patient with unexplained cause for altered consciousness. So these are some of the predictors. For example, previous seizures, non-epilepsy, fluctuating consciousness, or patient have impaired consciousness without explainable origin, we should consider EEG. But in the hospital without EEG or in emergency department, then I'll explain a little bit more later what else can we do. So I'll give you a few examples of non-convulsive status. A 48-year-old female with intermittent dysphagia. So she can talk, and after that, intermittently, she will become dysphasic for 5 to 10 minutes. So a few episodes in 1 hour, 2 or 3. So every 10 minutes, we will have one dysphasic episodes. Otherwise, in between, she can talk and follow commands. She is alert, conscious. And in this patient, we do a EEG show left temporal seizure during the dysphasic episodes. So this patient is having focal non-convulsive status epilepticus. As we can see here, non-convulsive status, beside altered mental states, some of them may have speech disturbance, subtle myoclonic jerks, abnormal behavior psychosis, and some of the psychosis that we see are in fact having non-convulsive status. So in cases like this, we will need to treat, but more gently, don't have to intubate them. Another example, 14-year-old boy with history of a GTC, but he also had history of absence seizures. And EEG showed generalized discharges. So what type of status did he have? He has absence status, which is a type of non-convulsive generalized status epilepticus. And it happened mostly in young patients who has history of absence or having juvenile absence epilepsy. This patient, we have tried to give phenytoin sodium valproate. It doesn't work. Midazolam gets sedated. Topiramate also doesn't. Etosasamide, we want to import, but you need an import permit and have to wait for a few weeks. So at the end, we didn't manage to control the seizure, but it stopped by itself after 1 week, which means this patient have intermittent, very frequent seizure every day for 1 whole week without response. So therefore, when we see non-convulsive status without EEG, it become a tricky conditions in Malaysia. So non-convulsive status, we think about it when there is unexplained prolonged consciousness, episodic or history of epileptic seizure. The patient may have epilepsy, for example, focal status or absence status, or patient may have other causes like infective, structural, metabolic, immune causes. So if you have EEG, we'll do. If we don't have EEG or EEG are not reported, for example, in certain hospital like Bintulu, they have EEG, then they can take a picture, send it or WhatsApp a neurologist and ask for their opinions. If not, then we can give a trial of benzodiazepine and see whether it responds. For epilepsy, we treat accordingly, but for those with underlying causes, we have to treat the cause itself. For example, if it's herpes simplex, encephalitis, if it's a stroke, if it is a uremia or sepsis, then we have to treat those causes accordingly. This is another example of status epilepticus, but this patient's status is convulsive but very focal. Her seizure is in the contralateral side of MCA stroke, which happened 2 years ago. So EEG show periodic discharges. You can see the EEG, which we record the jerk of the limbs, lower limbs in the EMG channels, and you can see in the middle is an abnormal brain discharges. So what it means is that this patient having continuous focal jerk of the thigh, and we call this status, focal status epilepticus or simple partial status epilepticus. In the old days, we use the name epilepsia partialis continua. Epilepsia partialis continua, if due to a stable cause like stroke, then we don't have to be too aggressive. You can take your time to slowly control the seizure, and usually it is refractory. Whereas for the more progressive causes like encephalitis, especially Rasmussen, those are very refractory, and most often we may need many anti-seizure medications, and some patients will need to have a surgery. So for our patient with stroke, we give phenytoin sodium valproate. It doesn't work. We don't want to intubate her and sedate, so we give lignocaine. Lignocaine is the same dose as what we use to treat VT. It doesn't work as well. So at the end, we want to use IV Mida, but it will sedate her. Oral carbamazepine also tried. All of this doesn't work and failed, but seizure stopped 10 days later. So we know that these are non-progressive focal status. Sometimes it will not to have a very aggressive treatment, doesn't have to sedate the patient or anesthetize or intubate the patient's seizure may stop later on. So the last part of our discussions is on home rescue. So if a patient having many long seizures, let's say one prolonged seizure a week, and usually up to 20 minutes, I have a patient up to 40 minutes as well. We don't want them to come to emergency every week. It will be very stressful for the family. So we want to try some home rescue. So what do you have, or what can be used as a home rescue? Rectal, yeah, rectal diazepam. Parker midazolam. Parker and rectal. In fact, Parker midazolam is getting more and more popular nowadays because of the easy in administrating that. Nasal midazolam, as I said, we need an aerosolized or atomized spray atomizer. And it will cost about 40 to 60 ringgit per atomizer. Thank you. So no one will consider oral clonazepam, huh? As you can see here, that many of the hospital or clinic, this is a response from the clinic, doesn't have any home rescue medication, or they don't provide home rescue medication to the patients. Hospital, yes, but not in the clinic. So it is a problem if the patients are first seen in the clinic, they wouldn't have any home rescue medications. And these are the two options we talk about, Rector and Barker. Barker is much easier to be given. And therefore, nowadays, we pre-mix or fill a bottle with midazolam and give to the patients. In Malaysia, we are not allowed to give glass bottles or ampoule to the patients to bring home. But we can pre-fill a small bottles, and the half-life, the lifespan of the midazolam in the bottle will last about 1 to 2 months. So for patients with frequent long seizure or prolonged seizure at home, we'll give a pre-filled bottle of midazolam, and they can use it as a buckle at home. It is easier and cheaper than vector diazepam. The preparation of the solutions is by our pharmacy, but according to them, they just pre-fill a glass bottle with the midazolam, which means they break the ampoules, pour into a glass bottle, and then normally they pre-fill about 5 ml per bottle, and then give it to the patients. Patient keep in the fridge. Whenever there's a need, they will use it. They'll just use 1 ml each, and it can last about 30 to 60. Yes, midazolam. Yeah, pure midazolam from the ampoules. Otherwise, we have to buy from UK. The UK prepared midazolam lasts about a year, but now the price has gone up to 1,000 ringgit per bottle, which is very expensive. The UK Barker midazolam is very, very expensive. So repetitive seizures is the same. So if someone having seizure cluster, 2 or 3 seizure at home, and very, very common to have patients with clusters at home. So whenever they have seizure, they will know that within the same day, they will have another 2 or 3. They normally doesn't want to come to hospital. Patient is alert, conscious. We can consider oral clonazepam. But however, if the patient is comatose, non-convulsive, more than 65 years old, no previous seizure, then they will need to come to emergency for further assessments. So oral clonazepam can be given in between the seizures while the patient is conscious and able to swallow orally. So not all myoclonic status epilepticus. We don't treat all myoclonic with drugs. For example, cardiac arrest. This is called severe encephalopathy with myoclonus. We know that the outcome is poor, and the myoclonus is due to the cardiac arrest or hypoxia, hypoxic brain damage, and it doesn't respond very well to most anti-seizure medications, although sometimes benzodiazepine may help. Second, myoclonus is patient on dialysis, which is called uremia encephalopathy with myoclonus. And this patient need dialysis rather than anti-seizure medications. Another myoclonus is a patient with rapid progressive memory loss, subacute dementia, subacute dementia with myoclonus provoked by noise. This is likely infective cause, which we call Creutzfeldt-Jakob disease or a prion disease. Again, this will not respond very well to most anti-seizure medications. In a very stressful conditions, we will use benzodiazepine. So desperate measure when someone have refractory and super refractory status, but most often when we reach this stage, the patient will have been taken over by the medical team. So what is refractory status? When they didn't respond to first and second line. Super refractory is after 24 hours. So what can we do when someone have refractory status? We know that the GABAergic drug doesn't work, the sodium valproate, the phenobarb, the benzodiazepine doesn't work anymore. We should consider glutamate-based medications like ketamine or perampanel topiramids. Lacosamide is working at the slow inactivations of sodium channel. In the old days, we have IV lacosamide, but after UCB has withdrawn themselves from Malaysia, we have no longer having any IV lacosamide for our use. But sometimes it's better to treat the cause because treating the cause will reverse the epileptic activity. And some of the treatment we have to consider is steroid or immunotherapy. Let me give you an examples. So this patient has NOS. NOS is new onset refractory status epilepticus. So patient had visual hallucination, aggressive behavior, no fever, and then having frequent focal seizure, doesn't regain consciousness, and he has orofacial dyskinesia. So the diagnosis in a complex case like this, which has psychiatric presentation, have dyskinesia, has seizure, we have to think whether this is autoimmune in origin. So autoimmune encephalitis, the commonest type is NMDAR, autoimmune limbic encephalitis. But there are other causes as well. For example, paraneoplastic Hashimoto, SLE, or post-infectious like herpes simplex. They may have autoimmune encephalitis after the infections. And these patients respond to steroid or immunotherapy. So we will always consider steroid, IVIG, plasma exchange first. If it doesn't respond, we may even consider rituximab in some of these patients. How about 5 years? 5 years is the same as new onset refractory status, which is NOS, but 5 years has fever. So patient presented with fever first. Looks like infective causes, but the CSF will be normal, and usually the imaging can be normal in the beginning, and we cannot find or identify any infections in the patients. These patients respond better with immunotherapy, and for pediatrics patients, they'll give ketogenic diet as well. Recently, we have a patient transfer from Singapore with fever for 2 or 3 days, subsequently getting more and more worsened in terms of conscious states, followed by seizure, which is focal, and then becomes status epilepticus. His interleukin-6 is very, very high in the CSF. And we give tocilizumab, and patient responds well. Patient has been was just extubated few days ago. So 5 years response to ketogenic diet and tocilizumab in Malaysia. Anakinra, we don't use that often for our patients. So in conclusion, time is brain. Think outside the box, not one size fits all, and in desperate situations, we'll try desperate measure, especially treating the underlying cause. So even though if the patient is first treated and seen in the emergency department, it is important to think that to treat the status as fast as you can, think about the etiology, and then try to investigate and treat the etiology as possible.